அம்மா இருப்பாங்க பாருங்க, கீழே பெல் அடிங்க.
Everybody mute yourself, please.
ஃபர்ஸ்ட் வீடு தாங்க, அந்த ஒரு கார் ஒன்று இருக்கு, ஒரு அம்மா தொடச்சிட்டு இருப்பாங்க பாருங்க. எந்த நம்பர்ல எந்த இடத்துல இருக்கீங்க?
Okay. Yeah. We are going live. Everybody stand by. Everybody camera on, audio off. Okay. We are going live. 5, 4, 3, 2, 1. We are live.
Good evening, everyone. We are having our live session today, clinical examination. Today we are discussing about basic things for undergraduate, that is surface swelling examination. Very common and very important for undergraduates, even postgraduates, because how to examine swelling, how to present the short case, sometimes in a long case, in a large swelling. So I thought we should have a discussion about that. So we selected this simple but important topic, basic topic. For this, I welcome my dear friend or other teacher, my guru, my boss, I can say, Professor Manoran sir. Sir, I welcome you very much. I welcome Muthukumar sir from Chennai. Sir, most welcome, sir. I welcome my dear friend, more vibrant Professor Robin. Robin, welcome you. You are always known to everybody now. Again, my dear friend, Dr. Professor Keshav Prasad from Sulya, Mangalore. Keshav, welcome you. And Sir Srinivasan sir from Palakkad, sir. Welcome you, sir, for joining us. Most welcome to you.
Good evening,
sir. Good evening, sir. I welcome, sir. And welcome presenting students Rishit Anand and Surikant S. Naik from Kasturba Medical College, Mangalore, final MBBS students. I'll welcome all viewers, all students from different parts of the country for this live session. So without wasting much time, we'll straight away go to the presentation. Sir, Manohar sir, Keshav, sir, Srinivasan sir.
Yes, sir.
Over to Surikant, he is presenting the history. Over to Surikant.
Yes, sir.
Lavanya, over to Surikant.
Hello, good morning, everyone. Today I'll be presenting the history of surface swelling. Can you just change this slide?
Lavanya, next slide.
So, the patient Mr. X, a 65-year-old male, who's hailing from Murdeshwar, and socioeconomically he is upper middle class. Next slide, please. So he came with the chief complaint of swelling in his lower back region in the right side since 1 year. Next slide. So patient was apparently in normal state of health 1 year back until he noticed a small swelling in his right lower back region. The swelling was sudden in onset and gradually progressive to the current size in the period of 1 year. He also had a history of slight decrease in the vision, and the swelling is not with any pain, discoloration of the skin. There is no other swelling in the body, and no history of discharge, no history of trauma, no history of fever and weight loss or night sweats. In the past history, he is not a known case of hypertension, diabetes mellitus, or tuberculosis, asthma, COPD, chronic kidney disorders, cardiac disorders, or any other comorbidities. No history of previous surgeries and no history of previous blood transfusions. But his wife had a history of tuberculosis, and there was no familiar history of similar swellings. Next slide. In personal history, patient was consuming mixed diet. He had adequate sleep. He had a normal bowel and bladder movements, consumes gutka, and no drinking or smoking habits. So, summary: a 65-year-old male who's a farmer by occupation came with a chief complaint of swelling in his right lower back. The swelling was insidious in onset and gradually progressed to the current size of 3 to 2.5 to longitudinal to transverse over 1 year, and is not associated with any other history of pain or discharge or change in color.
Okay, we'll go back to the first slide. Go back to the first slide. Next slide. Next. Anything to comment on this, sir? Robin, Keshav, Srinivasan sir, Manoran sir.
The next slide.
Next
You
slide.
have to mention whether it is chest or abdomen. Back side region of the right side you mentioned. Lower back.
Lower back.
Back right. Lower back correct.
Correct.
Lower back correct. Lower back correct, sir. Correct,
Lower
sir.
back.
Accepted. Lower back accepted.
Accepted. Okay, sir. Okay. Next slide. Sir, anything to comment on that? Gradually progressed.
Sir, in this he has written sudden onset. Can you elaborate more on that sudden onset?
That is what sudden onset. How you will explain, Suryakant? This is swelling you are telling.
What do you mean by sudden onset?
Means, actually,
Overnight?
sudden onset means he observed suddenly, not like when it was a small swelling, he just observed it accidentally.
No,
That is
even
what I
then,
meant sudden.
even then, no. That is a sudden observation. It's different from sudden onset, no?
Yeah, that's what you put it like observed one day while doing some work while feeding. Sudden onset means you say some other meaning for us. Unless
Because overnight, suddenly it has come in overnight. That is sudden onset. If it is anything other than that, this suddenly noticed is different from sudden onset.
After
And
history
what
of
size
trauma,
was it when it started? Is
Location is in the back, so patient would not have observed, sir.
observed, you would not have observed.
Observed, so
agreed, sir, but he has put it the way he has put it.
no, correct. What he says is correct. But the patient has noticed that swelling, all of a sudden.
noticed is the correct terminology.
He
After
should,
trauma, if there is hematoma, that is sudden onset.
yes, sir. He should have put the
That is
notice.
example.
Has noticed the swelling one day like that.
Why we are telling is it gives a different meaning altogether. You just casually mentioned it, but for us it has a different meaning when you communicate like that. Sudden onset.
Which all swelling must have a sudden onset, Suryakant?
But can you repeat, sir?
Which all swellings will have a sudden onset?
The previous slide you have mentioned.
Yeah, it can be a cyst.
Cyst
Sudden.
won't be sudden onset.
Sudden onset.
Hematomas can be.
Hematoma, abscess, acute infections will have a sudden onset. So, like Keshav rightly pointed out, notice the word, sir. Manohar sir has put a right word actually. Notice this one day. Like that, you put it simpler so that.
So last but one line you have mentioned no history of trauma. So Keshav sir said, no, following trauma, if you have a collection of blood, what do you call hematoma?
Yes,
So that is sudden onset. Okay.
okay, sir. Noted, sir.
So no, if you have other things are okay. Anything
No, and this what is the this thing? Passing one statement you again slight decrease in vision.
vision.
Is it related? When was it? When the beginning after 1 year?
Duration.
You have not mentioned anything about this afterwards.
Whether it is relevant to this problem or it is when it has happened, whether it is different time at all,
What exactly is slight decrease in vision?
and you have put in between this one, so we presume that it is related to this.
Yes, I was
Actually,
thinking some tumor has gone everywhere.
It's actually not related to this, but patient had complaint of this also.
Duration.
Elaborate
duration.
that now then.
Duration was around 1 year. It since 1 year.
So you should have put that one at the end of the history of present illness. He has got a slight decrease in the vision. This is not related to that, but it is there since long time. You have put this sentence in between the the swelling you have put.
I thought of putting about the negative history. So
Okay, but this you should have put at the end in the history.
sir. Okay.
The person also says that there is another complaint. You put it in the end of the thing. That will be-
End of it you can put. Sir, Robin, please.
So, Surya, your chief complaint of the patient is a swelling, yes?
Right lower region, we all agree to it. Duration is 1 year. Why did you describe it as noticed a small swelling? How do you quantify small? That doesn't look small to us. I think we all saw the patient's backside. It's quite big.
Like it's actually like a subjective to the what patient describes. You might
No. In the textbook, it's either in the patient's own words. Na? The patient can't say small, medium, size, large, XL, nothing like that. Na? So either they will say it was the size of a small pea or a small orange. Now gradually progress, like what you said too. You also said current size. So what was it before? What is it now? Either
like
in the patient's own words or like it's there in the book, fingerprints. Initially,
Yes,
it
sir.
was, we do not know because the patient has noticed it recently. Agreed. But you also said that the swelling was sudden in onset and gradually progressed to current size in 1 period. So the two sentences are not matching.
So actually, we meant to say that he noticed it suddenly. This is which was written is wrong actually, but it noticed it suddenly. According to him, it was a pea-sized swelling at the beginning of a year. Then it progressed a lot to this big of a swelling, which is the current size, sir.
And that's what. That's what.
So that's the problem.
He could have said patient noticed the swelling incidentally during bathing or taking when he rubbed his backside. Noticed incidentally and gradually progressed to the current size. That could have been a better word. Noticed, as Professor Manohar said, was noticed incidentally and gradually. You can correct that slide, nothing wrong in it. But the slight decrease in the vision, you have mentioned in the complaints, that could be the patient's complaint, you could have got it. But you could have elaborated on later on. Was the vision decreasing slowly? Is there anything? You could have added a point on that also.
At the end, put.
Okay.
Okay. So that point is very clear.
Swelling, SRB sir said, it's the most common complaint the patient presents to surgery with. A swelling. So site onset is very important. Like sir said, that sudden onset gradually progress to something we are thinking of. Like Keshav sir said, we are doing something sinister. Now, like Srinivasan sir said, maybe like okay, it was pea-size before. Now, incidentally, it is this size and it gradually progressed to something, but quickly. So, what if it was a benign transformation of, suddenly it has become a malignant transformation of a simple benign swelling? Could be, we don't know. Because if you look at the site, see, the whole point is we need an anatomical diagnosis. We need a pathological diagnosis by the time we are done with histopresent illness. Then we go to working diagnosis, differential and provisional. So when you look at the back of the patient, there are very few swellings which are in that region of the body. Right? So it's be very careful when you write those sentences. So character what was it and over what period of time did it progress? Relieving and aggravating factors, okay, you said no history of trauma, no history of discharge. It's quite unusual in that place. The sir has also noted, never put some things like a history of slight decrease in the vision in between the swelling. There's no point, unless, there's no point at all. There's no justification for that.
Yes.
Yeah. And there is no other swelling, matlab, you mean no similar swelling or any other type of swelling? We have got two types.
Like no other swelling in any other part of the body.
Part of the body, no other swelling. So no similar swelling or any other type of swelling.
No similar swelling.
Yeah.
Okay. Fine.
That's important.
So even otherwise, that swelling you could add it is a single swelling, no?
Yeah. Similar.
So you can tell
like in neurofibroma, lipoma, multiple sebaceous.
That last sentence, what are you thinking of? History, fever, weight loss, and night sweats?
Okay.
With respect to this swelling?
Surikant.
Yeah, we're thinking of like malignancy or TB.
Night sweats?
Swelling. Backside.
Night sweats, weight loss, fever.
Sir, maybe like in cold abscess kind of swelling,
Very good.
there is tubercular infection, so night sweats might be possible. That's why we asked.
TB is fine.
Rashid, just a second. We really appreciate you answering, but I think the question goes to Surya, so you cannot save him in the exam. So let him give it a try. Yeah.
Sorry, sir. Sorry.
Yeah.
It's okay. One of them can answer.
It will be teamwork. So you have no history of fever, weight loss, night sweats. You have a benign problem on one side, like is it probably TB, but you should be ready to say it. Now, cold abscess, is it a very common site? Okay, so the other aspect of malignancy, but in that region, I think my teachers should be the best judges for that. Which malignancy will present in that place with weight loss, fever, or night sweats?
Go to the next slide.
Next slide.
Do you think any other relevant history would have wanted to ask a swelling in the posterior aspect, swelling like that?
Any other relevant history you want to ask?
Maybe related to some organ.
I'm not aware of that, sir.
You're only thinking of a parietal swelling in this, or some intra-abdominal swelling which is coming out? Is it possible? Or at least like a bulge in the, if you look at that area.
You can
Could it be
renal.
Could it be a hernia? Could it be a hernia?
Any hernia can occur in this region, Rashid?
Manual laborer, farmer.
Sir,
Think of all the differential diagnosis in that area.
Yeah.
No, we will wait for the inspection and palpation, sir.
So after that, and we'll discuss. Okay.
Anything in the anatomy of that region, yeah.
Okay. Anything to comment on this slide, Keshav? Robin, Manohar, sir?
Because he has not yet come for the inspection part, he didn't come.
Yeah, this later. This is a
And
first.
no history of previous blood transfusions. That's the first time I'm sort of hearing it in past history, past is medical and surgical. Is there any relevance? You are thinking of something, or with the swelling? With the swelling?
That is mostly because even last time students were mentioned that contributions. Probably in medicine side, they regularly insist on putting that, I think. Here, if it is relevant only, they should mention anything. That is not necessary, I think. Manohar, sir, senior, sir.
Agreed.
Anything at all? No, yeah. No relevance to the complete.
If it is relevant only, you can mention. Even last previous presentations also students have mentioned.
Yes.
So,
What about this previous surgeries? What surgeries?
previous surgery, Suryakant.
Any surgery like Manoj sir asked in that region.
In that region.
What surgery?
And like Keshav sir also gave a simple question before. Is it possible that something can be not a parietal swelling?
A swelling occurring after a scar, what swelling do you think? A swelling occurring after a surgery through the incision, and that region, what is the organ? It could be any any kidney surgery done, following which a swelling occurs. You think of a lumbar hernia.
Hernia.
Okay.
Previous surgery is there, kidney surgery, then hernia can occur in that region, lumbar hernia. Location of lumbar hernia, probably you have to think of. Okay. So we'll go to the next slide.
Yes, sir.
Okay, family history. Wife had tuberculosis, any relevance in that, Suryakant?
He might be infected by the TB and
You not asked what tuberculosis, you ask little more detail, whether it's pulmonary tuberculosis, whether it is a sputum was there, what history she had, how long she had taken treatment, little more detail, because wife is very closest relative, they stay together. So treatment strategy was adequate or not, and that little more detailed history should be asked.
Okay, sir. Okay, sir.
What type of tuberculosis, what is the treatment, when she had tuberculosis, and she had a completion of the treatment. So those details are important here, because some part of the time receipt has told it could be cold abscess.
History of contact, and whether the patient is a defaulter.
effort, whether she has taken proper treatment or not is important actually. So you have to much more detail is required when somebody is having tuberculosis. That detail about type and treatment strategy, completion of treatment like the right treatment. Okay.
Sir, we didn't mention here, sir, but although we had asked the wife completed the treatment 1 year back, and it was pulmonary tuberculosis, the husband was not tested for it although.
Okay. Okay. So that is important. Treatment completion, all those things. Okay. So we'll go to the next slide, sir.
Yes, sir. Yes, sir.
Slide. So personal history, anything to add on to this? I think it's okay. I think it looks okay. Not on any treatment drug or anything. Next slide. So history summary. Here he has put insidious onset, sir. There it is sudden onset.
Sudden onset. Gradually progressive.
He has no teaser this word.
It looks much bigger than 3 into 2.5 centimeters. Anyway, in history you've mentioned it like that, but anyway, it's okay.
Bigger than that, quite big. Yeah.
So what do you think? After the history, what do you think could be swelling? What is your assumption?
After history, what do you think it is? What are the possibilities that you may have to wait till this is 1, 2, 3, 4 like this? So
it might be a lipoma or like cystic swelling like dermoid cyst or sebaceous cyst.
Dermoid cyst, sebaceous cyst is okay. Lipoma is okay. Dermoid cyst, what type of dermoid cyst comes here?
Very rare.
Not the site for dermoid.
Sebaceous cyst okay.
Sebaceous cyst is okay.
Lipoma okay.
Lipoma is okay.
Dermoid very rarely. Dermoid doesn't occur in this. Where does this dermoid occur usually? Surikant?
What is that?
Only can answer.
What is the prerequisite here?
Yeah. Sir, dermoid cyst of the ovary is also there, and dermoid cysts are common in the post-auricular region also.
Male ovary.
It is seen in certain areas.
Sir, I thought it was asked in general. That's
not me that.
In this area, what is the dermoid cyst you get? Do you get any dermoid cyst in this area?
not sure, sir. Not sure.
Sequestration dermoid, what is the prerequisite to appear?
Sorry, sir.
What is the principle why you get dermoid in certain areas?
Sequestration dermoid.
Congenital or sequestration dermoid, where do you get?
What is the underlying principle? Why you get in certain areas?
Along the lines of fusion, Pa. Along the line of fusion.
So here, no, there is no line of fusion, no.
It's in the side.
Line or wherever line of fusion it should happen. Understood, no? Rishit, Suryakant. So this is not,
yes, sir.
It's unlikely to develop dermoid cyst. So when you give a different, think of it, whether it is anatomically feasible to happen. Okay, so dermoid
It can be an abscess also. It can be an abscess also. A cold abscess. Cold abscess.
Abscess. Cold abscess. Somebody told this is the cold abscess. Definitely you have to think of differential diagnosis. Lipoma, then sebaceous cyst, cold abscess. These three possibilities. Maybe neurofibroma.
Hernia, lumbar hernia.
Lumbar hernia.
Lumbar hernia, neurofibroma.
Renal pathology.
Yeah.
Kidney mass.
Pathology.
Renal pathology.
And lipoma, of course. More possibilities. So like that, you should keep in mind certain, at least 4 or 5 conditions in mind. But in the meantime, we should rule out, not dermoid. Dermoid cannot happen here. Okay. So that's exactly you have to think of. So, sir, anything to comment on anything else to comment? Size
we can go to the next general examination.
Next slide. So Rishit, start presenting.
Yes, good evening everyone. Thank you. So I'll be presenting the examination part from here off. General physical examination. Before the examination, due informed consent was taken from the patient. The examination was performed in a well-lit and ventilated room. A bystander was present. Patient was conscious, cooperative, and well-oriented to time, place, and person. The weight was 68 kg, height 165 centimeter, BMI 24.9 kg per meter square. Next slide, please. Pulse rate was 72 beats per minute with regular in rhythm, normal and rate. volume, and character with a healthy, non-thickened vessel wall. The pulses were superficial pulsations were felt normal. We didn't write it here, sorry. Blood pressure was 120/80, right arm in sitting position. Respiratory rate was 22 beats per minute, abdominothoracic. SpO2 was 96% at atmospheric air. Temperature at the time of examination, he was afebrile. Next slide, please. Head to toe examination, pallor was present. Icterus, cyanosis, clubbing, lymphadenopathy, edema were absent. A whitish opacity was visible in the pupillary area of the eye. The scalp, face, ears, nose, mouth, neck, chest, abdomen, spine, and extremities were normal in appearance. Local examination. Should we continue?
Yes, we'll discuss later.
Local examination, inspection. So there was a swelling noted on by the look. We thought it's around 16 centimeters from the inferior from the spine of right scapula, 4 centimeter medial from the right posterior axillary line, 5 centimeter from superior from PSIS, 2 centimeter lateral from the vertebra. Size was 12 centimeter into 10 centimeter assumed on inspection. Shape was oval, surface was smooth, and there was only one solitary swelling present. Next slide, please. There was no color change visible. Skin over the swelling appears to be normal. Movement does not move with walking or moving of the limbs. Pulsation was not present. No visible sinus or dilated veins. Then palpation. Inspectory findings were confirmed. There was no local rise of temperature. No tenderness. The surface was smooth. There were well-defined and regular margins. The consistency was actually soft, not firm. I remember, I'm sorry for this typo. The consistency was firm. It was soft in consistency. Next slide. So this shows the pictures while we were examining him. Pictures of the swelling. Next slide, please. The last picture in this and in the previous slide shows the slip sign positive. So while examining, the fixity to the muscle was present. The compressibility was also present. Fluctuation was absent, and slip sign was positive. There were no palpable right axillary lymph nodes present. Since the swelling was above the umbilicus, we tested for the axillary lymph nodes. Next slide. Systemic examination. Should I continue?
No, you can skip this slide.
Normal. Let him finish up.
Finish the examination.
Yes.
Let him go through, sir. Continue.
Systemic examination. CVS, S1, S2 were heard. There were no murmurs. CNS, no focal neurological deficits. RS, normal vesicular breath sounds were heard bilaterally. Spine examination was normal. Next slide, please. Summary. Based on the history and examination, 65-year-old farmer came with complaint of swelling on his right lower back since 1 year. On clinical examination, he was having pallor, a swelling measuring around 3 to 2.5 centimeter in size with clear margin, smooth surface and oval in shape. The swelling was soft, not firm, and there was no fluctuation, and it was fixed to the underlying muscle, and slip sign was positive. Next slide.
Go back to the examination, general examination. General examination. Okay. Anything to comment in this, Keshav, Mandoran sir?
Sir, ideally speaking, this is actually a short case. So such a big one is not necessary in the exams. But since it's a teaching platform, let him tell about everything, sir. But in the exam, lipoma, as you know, lipoma is a short case. So we ask for the complaints, positive findings, and positive inspectory findings, and finish up with the diagnosis.
But here
we agree, sir. But let us not come to the conclusion it is lipoma. But the inspection palpation part, we have some questions to ask.
Next
yes, sir,
slide.
definitely.
And apart from slip sign, it doesn't have anything to say that it is a lipoma.
Next slide.
Yes, sir.
Slide. Next. Here, sir,
Opacity in which eye?
eye whitish opacity, what is that?
Both eyes or single eye?
Sir, both eyes.
Both eyes.
What is that eye whitish opacity?
Sir, look like immature cataract.
Cataract. Okay, immature cataract. Okay.
Vision is there?
Sir, vision is blurred.
Oh, that's why history you have put vision, blurred vision, probably cataract.
Okay.
Okay.
Yes, sir.
They have put in the in between the swelling.
Yes, sir. Yes, sir.
Okay, that's the only thing. Little more. Okay. Next slide. So here, sir, anything to comment?
So again, in this, there is a systematic way. No, you have given the extent first.
Site should be mentioned.
Yes, sir.
Yes, a single swelling of size. That's how you describe. No, solitary swelling of size 12/10 is seen in the right lower back.
It is like
Better way of telling. No?
it is better to tell in a sentence, lucid language, not to put a side like what is mentioned in the book. It's not like to put it in a sentence, like a single solitary swelling of size and located in this area from this the centimeter from that point. So your points are correct. We are not questioning it, but to make it in a sentence in a
Yes, sorry, sir.
language.
So mention about the skin also. Skin appears normal, no? Over this.
Here you mentioned about extent. You mentioned extent in relationship to scapula, which is 16 centimeter away. But here we want to know whether it is related to the lower ribs or not. If you mention in relationship to rib, because we are thinking in terms of renal pathology, we are worried about renal angle. We are thinking in terms of cold abscess. So we want in relationship to ribs. Absolutely. Is it overlying the lower ribs or is it below that level?
And scapula will change position, no? When the arm is abducted, scapula position will change.
Scapula will move, no? Scapula will move while circumduction or abduction or...
It's not fixed. So it is not ideally to a good point to take.
Rightly, sir. Kumar sir has rightly told. You have to better to mention the which intercostal space. For last, whatever the lowermost space, upper part and lower part, if you mention which rib, that will be better better locating point rather than scapula. Okay.
What is renal angle?
How about like in
renal angle? What is renal angle? Renal angle. Tell me.
Renal angle, Rishit.
Sir, I'm not very sure like what exactly it is.
Suryakant, you can help him?
I'm not sure, sir.
Not so.
It is lower border of the 12th rib and lateral border of the erector spine.
So renal
swelling is lateral to the midline. Correct. What about the lower border of the 12th rib? Is it above that level or below that level? We don't have any idea. So whether it is related to the renal angle or not, we don't have any idea. You have to mention it in relationship to the renal angle if you want to rule out renal pathology.
And you have to compare to opposite side. That is a very important point to mention, especially swelling like this. Okay. So rib told you should mention relation to the ribs, so that is better than scapula. And other points, of course, it's definitely accepted. As vertebra, superior PSI, all those things. But like Keshav again rightly told, mention the swelling, dimension, shape, everything, and of course location in a continuous language, lucid language, I think. Manohar sir, anything to comment? Robin, you want to add on to this? Probably it is that's a little more.
The next
I think, sir, the spine of scapula is too far and vague. It's much lower down. We are thinking of differential diagnosis in that region.
Yeah, that region. It is rather very low.
Lipoma, lumbar hernia, inferior petit angle, everything is in that region. So
yeah, I think rib should be the right marker to mention the location properly, I think.
Next slide, sir.
Yeah. So next slide. Skin over the swelling he has mentioned here. What is the movement? Movement does not move with the walking or moving the limbs. So
which one will move?
Relevance, Rishit. Why you have done that and how it is relevant? Keeping what in mind you have done that? I am confused.
Sir, actually,
movement with the respiration, you could have said something.
Yes.
Moving with respiration. Is there any cough impulse or increase in size during? Increase in size during?
Expansile or coughing?
Increase.
Cough impulse.
Cough impulse important.
I was waiting to tell that.
Increase in size.
Tell me, what is the importance of movement?
So movement with respiration.
Tell me the relevance.
Sir, actually, we wrote for movement in case if the swelling is attached to the muscle. So while if like latissimus dorsi comes there, so in any of the action of lats, if the muscle is
But
moving or
will the muscle
contracted, like
move
in
when
that sense,
somebody
I
is
wrote it.
walking or moving?
No,
Sir,
walking,
actually, the state.
Those muscles
Yeah.
move, no?
So
walking and moving is we are really confused. I was thinking what exactly you have kept in mind by doing this one.
actually, sir, we asked him to do the rowing action and adduct his arms like.
No, but that's not normal movements, no? The rowing, no, while walking, who will row?
Yeah. That means you have to mention
Yes, sir.
specific movement, not a gross mentioning like this. Walking, this swelling will alter by walking.
The muscle has to be the muscle has to be put into contraction means what you should ask the patient to do in this particular location. You want the underlying muscle to move.
So
Yes,
for making the muscle contracted, the rowing action can be done. He can be asked to take his arm.
Rohit, Rashid, you are fond of rowing, I agree. But tell me, how will make this particular muscle below that swelling to contract?
I will make it contract. This is
Any action except rowing.
Sir, he needs to. Otherwise, he can also adduct the arm against the resistance.
Then
That is also to contract.
you can ask him to bend downwards.
Bend downwards or
He can
like
turn.
that.
He can turn. Fix the hip and ask him to turn either side, this
Yes,
side,
sir.
that side, and rotate the spine.
Against
I
the hip.
think
he
like
can
sir,
press.
Srinivasan sir told, cough impulse is very, very important.
So I was waiting for that. Sir told.
have you mentioned cough impulse? Have you checked
No,
the
sir.
this is
Pulsation is mentioned, but not about cough impulse.
So cough impulse, we thought that it like I
Very, very
that I
important.
thought it's
Very, very important because it is communicating to the spine or to the abdomen, and we talked about hernia also. So the
Yes, sir.
cough impulse is very
close to the lower ribs also. So
yes.
cough impulse is very important. So if you are not mentioning cough impulse, it is a shortcoming actually, Rishit. You should mention the cough impulse. Krishnan sir has rightly pointed out that absolutely you need to mention. But they are very vague about this movement with the moving lips. So that is.
sorry, sir. This side thing. I'll change it, sir. I'll change it.
Yeah, you have to correct it. We are not questioning you. We are correcting it. So,
So the movement with deglutition, movement with protrusion of tongue, movement with respiration, and basic movement with the muscles, whichever is involved with the plane of the body. These are the types of movements we have, no?
Yes.
So pertaining to the case, you tell us, yeah, because see, look at the anatomy. It's near the erector spinae and your back knuckle. So whatever, like what Manohar sir said, simple bending over, don't you think you will see some movement? Cough impulse, isn't it important because that particular place which you have marked is notorious for in anatomy. There is a name for that itself.
I mean, lumbar hernia is differential.
Yeah,
So
the two triangles are there. No, one is superior lumbar, one is inferior lumbar. So those are important, right?
yes, sir. Yes, sir.
Yeah, because like Srinivasan sir said, these sort of cases are short cases. We agree, but we it's a teaching forum, so we want to cover everything as a long case. But make sure you,
Yes, sir.
yeah. So swelling, there is no excuse. You have to go in order. That whole thing, it has to come in order.
You cannot change the order.
Sorry, sir.
Pulsation not present. Visible pulsation in that region. Okay, no visible sinus or dilated veins. Okay.
that's okay. Next slide.
Next slide.
Palpation. Okay. Anything to local slenderness, smooth surface, well-defined regular margin. Firm. He said firm, but he's telling it is soft. So is it soft or firm?
Sir, soft.
What is the plane of the swelling?
Plane of the swelling. Mobility. You checked. Next slide.
Yes, sir. Mobility we had checked, sir. It was freely mobile actually, both in the horizontal, both in the craniocaudal direction and also mediolateral direction. It was mobile.
Next slide.
Is it below?
Plane of the swelling is plane of the swelling.
How is it mobile if you said it's fixed to the muscle?
To the muscle you are telling, and you tell
What
it
muscle?
is mobile.
So like it was like when we were trying to move it, it was moving, but when the muscle was contracted, then it was
Which
difficult.
muscle?
Which muscle?
Sir, I think, sir, maybe latissimus dorsi.
Go lower.
Okay, which muscle is we are while contracting muscle, it is moving restricted or not? Here.
Sir, while contract.
I will contract latissimus dorsi.
Sir, we can ask the patient to like adduct his arm and then push it backwards so the muscle will contract.
Extension or
Extension.
against resistance or
Against resistance.
against resistance.
You have to understand one point. If your swelling is related to a muscle, even if it is fixed to the muscle, it will have mobility.
Restricted
Muscle
movement.
mobility will be there. Only if you
Yes.
contract the underlying muscle, the mobility will be restricted.
Yeah, that's what exactly happened.
That you have to mention. After contracting the muscle, you look for mobility.
Yes,
Then
sir.
you will understand the difference between it.
That's what
Example,
exactly.
breast lump.
No, yeah,
It
if
is mobile.
it is beneath the muscle, if it is beneath the muscle, if you put the muscle into contraction, the swelling will decrease in size.
Very
You have to
it will
look
be
for that
less prominent.
also. You put the muscle into contraction. One is you look for the mobility, look for the size. If it is above the muscle, it will become more prominent. If it is less below the muscle, it will become less prominent.
That is,
So when you say that, you have to say, as
Rashid, what is the
fixed
plain?
to the muscle, it may be just fixed. Plain here, sir, you didn't say. Was the skin pinchable?
Pinchable.
Sir, skin
Was the
was
skin
not.
pinchable?
Sir,
Is it
skin was
arising
not.
from the
Skin was easily pinchable, sir. Skin was
So,
easily pinchable.
Then, so you rule out
Pinchable.
sebaceous cyst from this. You rule out sebaceous cyst from this one. Okay. Skin was
Yes, sir,
pinchable.
yes,
It
sir.
is in the subcutaneous plane. Now, if it is the subcutaneous plane, is it fixed to the muscle or deep to the muscle? So
Sir,
you
I
said you
think
put
it
the
was
muscle
an
into contraction.
Sir, I think the plane of the swelling was intramuscular in nature.
So
because-
what happens to the size of this swelling when you put it into contraction?
Sir, when the muscle contracts, the mobility of the swelling will restrict and it will.
Sir is asking about
The
size.
size should decrease. Sir, slightly decrease.
Becomes less prominent.
That will be
Less prominent.
so it
What about
is
the things?
intramuscular.
Sorry, sir.
Rishit, what is compressible swelling?
That's what I was waiting. Second line.
This is
What is
Controversial point.
compressible, reducible?
Simple and
Tell with example.
what is compressibility?
Sir,
Because if you are-
compressibility is.
Define it.
So compressibility is when we press the swelling, it compresses, like it goes in and then it comes back, bounces back out. Whereas
back.
reducibility.
Goes in and comes up back means it is hernia.
No, I mean it's
No,
reducible.
No, sorry,
Is it-
sir. Describe the compressibility, then the answer will come automatically.
With one example.
One example.
Give example.
You should know why we are telling this, because if your diagnosis is lipoma, it cannot be compressible swelling.
Cannot become.
Your diagnosis should be based on your findings. So what finding you tell is very crucial. If you tell compressible, then you can't give a diagnosis of lipoma.
So which use few two examples of compressible swelling, Rashid.
Yes.
Sir,
It might be hematoma. Like,
Surek,
Rashid, see, compressibility is one where the swelling, when you put a pressure on the swelling will completely disappear or partially disappear, but doesn't need an external force for the swelling to reappear.
it
doesn't need an external
when it
force to
contains
reappear.
fat or blood.
Where it is a hernia, it gets reduced completely, the swelling disappears, but you need an external force for the swelling to reappear. You need to cough or stand up, so the hernia appears. That is reducibility. Whereas
Yes, sir.
compression, you can partially reduce or totally reduce, but automatically it gets back.
it's back
It is
to
not your original size.
original side. So by definition,
One is aneurysm or AV fistula or hemangioma.
Hemangiomas.
AV fistula.
hemangioma,
is one
lymphatic, vascular malformations are compressible. So moment you say it is compressible, we will think on that side. So we will forget lipoma. So you can't, once you say it is compressible, you can't say lipoma. So you should be very careful what is compressible. So this cannot be compressible. You really got compressibility in this patient, Rashid? You are mistaken
Sir,
because it is
Maybe sir, my examination was mistaken because I tried doing that. Maybe my interpretation was wrong of it.
Like sir, Srinivasan has clearly defined it how exactly it meant properly actually. So whatever his wordings will not suit to this swelling actually. So you listen to his wordings, it is unlikely to be compressible. Very clear. There is no confusion about to define definitions here. Sir has told properly, proficiently. So
Yes, sir.
everybody will understand the meaning of the way he has told. Very clear. Understood. So it is not compressible. Don't get confused. Okay. There are only two structures like sir rightly told. Vascular malformations, sometimes lymphatic malformations are compressible. So you have to be very, very careful when you use swelling is whether swelling is compressible or not. Be careful. If you think it is lipoma, tell it is not compressible. Deeper site. Okay.
Yes, sir. Yes, sir.
Okay. So fluctuation absent, cliff sign is positive, no palpable right axillary lymph nodes. So another thing Muthukumar sir told. So if it is related to the muscle, it will be mobile when you don't contract in both sides. But once you contract the muscle, mobility will be restricted. This is what exactly probably happened in this swelling.
In this swelling, when the patient was lying relaxed, there was no muscle contraction. The swelling was mobile, freely mobile, both craniocaudal and mediolaterally. But the moment we contracted the muscle, the movement of the swelling was restricted. The mobility was restricted.
And second,
you have mentioned about prominence of the swelling also.
Yeah, that's
Yes.
what.
Because more prominent or less prominent.
Whether it is prominent, whether it is less prominent, whether it is mobile or restricted mobility. So the points clearly raised by Muthukumar sir and Srinivasan sir. Understood that points are very, very clear. Most important.
But Rashid, what is the fluctuation?
What is fluctuation?
Sir, fluctuation is usually seen, sir, in the swellings which have fluid inside it. So when we try to examine it, we keep the index finger on the one margin of the swelling and the ring finger on the other, and then we try to press it from the finger. And if there's a fluctuation, if the fluid comes out of the other part of the hand, it means that there is fluid inside the swelling. But in this particular case, I thought there was, because since by that time I had in mind it might be a lipoma, so pseudo fluctuation was something which I was thinking of, because when I was pressing the swelling, I felt like something is coming, not very prominent, but maybe the soft tissue inside would have been fluctuating.
So this is not
when you say pseudo fluctuancy, you correctly said it is pseudo fluctuant, because the lipoma in this body state will be in the liquefied state. Okay, and the globules, fat globules, will transmit light. So you will have a pseudo fluctuancy and a pseudo transilluminance. If it is a huge lipoma, the fat inside is actually it will in the liquid state. So you will have a pseudo fluctuancy. It gives you a feeling of fluctuancy. And number two, that pseudo fluctuancy flat globules will transmit light, but it will not be typical illumination on the opposite side. You may get around the swelling. If you get transilluminancy on the opposite side only, you can say it is transilluminant. Around the swelling is not transilluminant.
And another thing, all of you should know how to elicit fluctuation. You have to always prerequisite. You have to fix the swelling. You should be able to fix the swelling. If you won't be able to fix the swelling, you cannot elicit fluctuation. And fluctuation, you should always elicit the full movement in the two directions perpendicular to each other. According to the Pascal's law. And when you exert pressure, you will move equally in all directions. That's the Pascal's law.
What about fluctuation in a small swelling?
In a small swelling, how will elicit fluctuation?
What is the name for it?
It's too small.
There's a test named for it. There is a test named for it.
Pages test.
So fix the swelling.
You mentioned about
transformation here.
You mentioned about axillary lymph nodes.
Yes,
in this
sir.
case, axillary lymph node is important or inguinal lymph nodes?
Sir, the swelling was above the umbilicus, so that's why we checked for the axillary lymph node.
You see the picture?
Your extent, when you mention about extent, all these points are important.
Yes,
So if extending below the line, and then you have to examine inguinal lymph nodes also. Here, probably, that's why umbilical level is important. If it is above the umbilical, you have to mention. He has mentioned somewhere, I think it is above the level of the umbilicus. So that's important, like sir has rightly mentioned, such swelling, umbilical line you have to draw and check. whether it's above that level or below that level. So drainage will become both sides if it is at the junction.
Yes, sir.
So, and another thing, fluctuation in the abdomen is not possible. So any abdomen, not abdomen wall swelling, intra-abdominal swelling, you cannot fix the swelling. So cannot elicit the fluctuation. That's again additional point you should remember.
Rashid, what is this slip sign?
Sir, slip sign is a characteristic of lipoma mainly. So when we press from the edge of the lipoma, like the swelling, it slips onto the other side. So that is
Why it slips?
sir, because of the I am not very sure, but I'll try. Sir, because the fatty tissue inside, which is the main reason of the swelling, that adipose tissue is in semi-solid state.
Okay,
So when we
we'll put it the other way. All lipomas will slip.
No, sir, it's asking every lipoma should slip.
No, slip sign is lipoma, agreed. I am asking whether all lipomas will have a slip sign.
Sir, if the lipoma has developed any complication, like it has progressed towards liposarcoma.
No, we will talk about normal lipomas.
Lipoma will not turn into liposarcoma. That is the
current theory.
Sir, not very sure, sir. I think most of the time slip sign is positive. If there is any condition where it is not exception, I'm not aware.
The question is why it is positive. That's all, simple.
Sir, it's positive because the fatty tissue, which is responsible for the
all lipomas will have fatty tissue, no?
Sir, what if the lipoma has an intramuscular attachment?
Rishit, the lipoma clinically is divided into diffuse lipoma and encapsulated lipoma. Diffuse lipoma, the fat just gets deposited like anything in the body. In encapsulated, it forms a tumor where there is a deferent capsule. So when you keep your finger at the edge of the swelling, the capsule slips under your finger.
Understood.
That is why it's called the slip sign. So only encapsulated lipoma will slip under your finger.
That is why there is
diffuse
lipoma will not slip on their finger.
Yes. That's why diffuse lipoma will not slip. Okay. Only localized encapsulated lipoma will slip. You got the answer?
Yes, sir.
Has rightly put the answer. Is it clear?
Yes, sir. Clear, sir. Got it, sir.
We'll go to the next slide, sir.
Yes, sir.
Because one possibility is cold abscess, you can mention about the examination of the vertebra. What is gibbous?
Spine examination. Yes, put spine examination, sir.
Yes, what is gibbous? Gibbous.
Gibbous.
Spine examination. Okay. You have to look for deformity, paraspinal spasm, spine tenderness, then spine movement. If you are thinking at least these four things in the spine, we could mention.
And calf impulse.
Yes.
That is calf impulse.
Okay. Next slide. So again here he said the dimension is 10 centimeter 12. Here you are telling 3 into 2.5 centimeter. Keshav, I got confused.
Two different people have made slides. They have not communicated with each other.
Suryakant told on inspection 3 into 2.5 centimeter. You told on measurement it's the 12 into 10 centimeter. And somebody into 2.5 centimeter. Understood the Rishit? There is confusion. Okay. Now which is right? It must be 12 into 10 centimeter. Am I right?
Yes, sir.
At least something like that. 8 or 10.
Sir.
Very small, like 3 centimeter. Okay. So always tally your findings. Important when you write a summary. So always reconfirm with the findings. When you write.
Yes, sir.
Okay, that's important. So we'll go to the next slide.
Yes, sir.
So diagnosis, sir, this is what exactly he put. Manohar sir, Robin, Srinivasan sir, Keshav, Muthukumar.
Yes, sir.
And this we have discussed the differential diagnosis. Then when history only thought same thing you have put neurofibroma, sebaceous cyst, cold abscess. But final clinically intramuscular lipoma he has put. Why you said it is intramuscular lipoma? Give some reasons. So
Sir, because when the muscle was contracted, the movement of the swelling was restricted, the mobility of the swelling. So we thought that it is attached to the muscle.
Why you said it is lipoma?
Sir, lipoma because slip sign was positive. That is one characteristic feature. Then pseudo fluctuation I could feel. So that is the second point. And it was soft and doughy in consistency also. So abdomen was
The doughy color, soft and
not doughy. I mean soft.
what is doughy killing? Soft will not be doughy, I think. Robin
Yeah, sorry, sir.
is doing better than that.
Where do you get doughy?
How the lipoma is attached to the skin, Rashid?
Sorry, sir.
How the lipoma is attached to the skin? What is
Sir, I
that?
didn't understand like how.
Lipoma is below the skin. Is there any
Sir,
attachment
I was asking about the plane of the swelling.
of the swelling? You said
Sir, if the swelling, if the lipoma will be attached to the skin, or if it will be a sebaceous cyst, then skin pinching we can say.
we are talking about lipoma only.
If it is attached, how it is attached?
There is one more sign which you have not mentioned in lipoma. Other than slip sign, pseudo fluctuation, translamination is of course to be done. It's found only in subcutaneous, not in other types. There's one more. That's what sir is asking. Lobulations. Where is lobulation?
In a large lipoma, lobulation is very common to see and feel.
You have to glide the skin and see.
Yeah, skin and see and feel also.
When you glide, you will get that fatty strands attached to the skin.
Scans you will get.
Because yes, sir.
Lipoma, we will ask you what are the points in favor of your diagnosis always for short case. No doubt, in a 10 minutes exam. First, you start off with the chief complaint of your swelling. What is the site of the thing? That itself will give you a clue, no? For instance, if we are asking you, you already know the answer to this. Which are the places where you will find a lipoma? I'm sure you will say it is a universal tumor found everywhere in the body. Yes? Absolutely correct.
Yes, sir.
Surya, which is the places where you will not find a lipoma?
Sir,
No. The question is to Surya. I saw him just dozing off, so I thought. Yes.
Just
Where do you not see lipoma? According to Rishit, lipoma is a universal tumor. It is ubiquitous tumor. It is all over the place. It can be solitary. It can be multiple. It can be encapsulated, diffuse, painless, painful. These are the 15 different types of according to planar swelling. Despite all these features, is there any place that you don't find it?
so what about the palm of the hand?
What about no? You have to tell us. You cannot ask us.
The palm of the hand.
That is for sebaceous cyst.
So when you incision here, the first thing you will not see that yellow thing. Why do you think this is soft? When you lift your dumbbells, why do you think you lift to this place? You won't feel any problem.
Because of the fat.
The fat pad is there. Fat pad. It's just a joke. It's just a joke that we
there is no fat.
during the viva we play with students that it's the one place, the one organ in your body you don't use for the exam.
sir, it's only one place where it cannot be. May I?
Yes, that's what lobulations are important. Manohar sir has told. And whatever differential diagnosis, sir, Manohar sir, whether they should keep in mind, I think they should have, when discussion comes, they should mention, I think, all these differential diagnosis.
Why do you say it's not a sebaceous? To keep the ball rolling.
Sir, sebaceous cyst skin pinching is not possible. In this case, skin pinching.
Yes, good. Yes, skin pinching is not there. There is no punctum.
It's important.
There's no punctum. Okay, there is no punctum.
Yes, sir.
There is no loss of hair. They submit, and it will be pultaceous material, so it can be indenting on palpation. That is, it can be molding. Sign of molding is there.
Molding side.
Molding will be there.
And sir, also sebaceous cyst can be a fluctuant also.
It's not fluctuant. It is called a sign of fluctuation. It contains clay-like material inside. So when you compress it, it can mold to any shape.
Indentation.
Or sign of indentation.
Indentation. It's
Sign of indentation.
It's a molding. It's the molding sign. It's very typical. So,
Which is the other swelling you will find sign of indentation other than sebaceous cyst?
Sorry, sir.
Which is the other swelling other than sebaceous cyst where you will find sign of indentation?
Where else you can get?
In that particular swelling, there's a term before we use indentation. And
Where,
that is very important also before you put a knife on that patient.
Sir, I read this somewhere. I'll say that because I really did, but I don't remember. It was there in the book. I remember that thing.
Surikant, any idea? What is the idea?
What is the swelling?
No idea, sir.
No idea. He is very clear about that. Robin, you can answer them.
Dermoid cyst, bony indentation.
Dermoid cyst.
Dermoid cyst, bony indentation.
Dermoid cyst.
We do not see lines of fusion. We do not know the extent of it. We never put it at the minute you find the bony indentation, which means you can find it going into the bone. You take the next investigation. Don't put
Again, yes. Again, remember here, dermoid cyst will not come. It's not in the line of fusion. Already Srinivasan sir has told. Manohar sir has told. So we talk us in the line of fusion. Remember dermoid cyst. Otherwise, don't tell that. But
so cold abscess with the location site. Okay, sir. One last question with the neurofibroma. Do you think neurofibroma will have such a big mass, such a big lesion? It can be single, it can be solitary, it can be multiple. Multiples are the ones we commonly see. Can you give us one clue in your history? You've taken a detailed history, either Surya or Rashid, it doesn't matter, to tell us that probably you think of a neurofibroma.
The neurofibroma might be painful.
No. You have mentioned it, and we kept asking, why did you ask that question?
neurofibroma, what are the typical features? Is it soft, firm, or hard?
Sir, it's a firm and it moves in a transfer direction, not in like longitudinal direction, along the line of nerve.
The peripheral nerve, along the nerve, it's on the nerve sheath. You have neurofibroma, you have a schwannoma, and you have a neurolemoma. These are three different things, three different sorts of planes. Our question is very simple from history. Is there anything to suggest that this could be a neurofibroma?
Here, just a minute, we are put a differential diagnosis. I know it is not, it is not.
Just one point. You just give something from your history. That is the one thing that we were not ready to agree with you. No?
Arvind, you can answer them.
Why did you ask for that decreased visual acuity? Is there any correlation? We asked you that. Is there any correlation with that and neurofibroma? Is there anything at all?
Yeah, here it is the patient is having cataract, but otherwise, will you correlate and tell it is neurofibroma? That's what Robin is asking.
Yes or no, Rishit? Anything you can decide. Yes or no? Nothing. No relation. Pass.
Sir, when we asked about the vision thing, we never thought of correlating it, to be honest.
Yes, but you should always be when you put a differential. We know that you will answer everything of sebaceous cyst. We know you will answer, but neurofibroma is very interesting. When it comes to these eye signs, you have two types of neurofibroma. You have neurofibroma type 1. You have neurofibroma type 2. You have lot of eye signs. You have something called leash nodules that you see in type 1. I'm sure you've heard of these things, right? The type 2 is even more interesting. You have gliomas. You have juvenile cataracts.
I know, that's what.
Is it possible that this patient had a problem from before?
If there may be association, maybe intracranial.
It's very interesting. Neurofibroma is very interesting topic. That's the only thing that you put extra, and that was, I thought, at least you would answer that one sentence which we did not agree with you. We kept quiet thinking we'll ask in differential, but you unfortunately put neurofibroma.
So
that's good. Yeah.
I'll read about it, sir. Maybe not.
Yeah, it's very interesting. It's very nice. The gene inheritance on both are totally different genes. Chromosome is the same, but the gene is different.
We'll accept your diagnosis lipoma, but the DDs are discussed anyway. So we'll go to the next slide.
Yes, sir.
Okay. The investigation. Read the investigation, Rashid or Surikant. Rashid, read the investigation.
Yes, investigation, sir. We USG, CBC. blood grouping, and then RBS and FBS, then RFT and LFT.
Why blood grouping?
Sir, actually, blood grouping was not like there's no chance of bleeding or hemorrhage much in this surgery, but still this.
Okay.
No. You're giving an exam. Please be a bit when you ask. See, you want to investigate a patient. You have routine, basic investigations. You have specific investigations. Obviously, we are surgeons. We are going to operate. We are going to put the knife on the patient. There is no question of applying liniments and ointments on this patient. So for that, routine, basic investigation, whether it's general anesthesia, depending on the size of your lesion, or is it local anesthesia. This is quite a big lesion, so probably the patient will require some sort of GA or maybe short GA. So don't you think simple things like starting from CBC, LFT, RFT, blood and RH, supposing you encounter bleeding, don't you think you want to be ready with some sort of transfusion?
Yes, sir. We need to be ready.
Especially when you're at the back of the area, we are not sure what it is. We are not sure because you have missed out the most important investigation in this patient.
Right.
You could have added BTCT, a coagulation profile. That would have been better.
Yeah,
See, there was a famous quote telling that you treat the patient, not the disease. So you think of the patient, a small swelling, you do an array of investigation, the patient will not come to you. They'll go to the next person. Okay, we can do it under local anesthesia. A coagulation profile will be okay. An ultrasonography is okay. Why you left out FNAC?
Sir, I was just about to ask that this is the most important investigation that you have not done.
Why you have not done FNAC? And sir, whether we need to do MRI in this patient currently, of course, Sriram sir, currently patients want more investigations. They will ask whether you need MRI. They will ask you. There is a trend now because of the Google doctor.
Yes, sir. Now, ultrasonogram has got a 95% sensitivity and specificity, also 90%.
FNAC
that is enough, but in certain areas, an MRI will be helpful, but not here. See, it is superficial. Is that one? Sir said, since you said intramuscular, an MRI will suffice. For your safety and litigation purpose, you can take an MRI because it's intramuscular. Because once you start putting the knife and going in, if it goes into the muscle, you would like to know the depth of the swelling. Is it going beyond the muscle? How far it is going beyond the muscle? Is it touching the bone? So an MRI is mandatory in this case, but not in all lipomas.
MRI is accepted in this case, definitely.
Any swelling in specific investigation, the most important investigation for any swelling. Don't you want the patient wants to know if it's benign or malignant, right?
Tissue diagnosis.
Yes, sir.
A simple FNAC would suffice. Simple FNAC.
Ultrasound, FNAC, and MRI. These are the other things are, of course, for treatment. The other thing, these are the basic relevant investigations you have to include this patient to be basically. Yes. Okay. So we'll go to the next slide. So treatment excision of intramuscular lipoma under spinal or GA. Under local, better to have a spinal anesthesia or GA because it is a deeper intramuscular. I think better. Okay. So next slide. So just
send excision and send it for histopath. Send it to pathology, histopathology.
So always send it to histology. Anything removed, you have to send it to histology.
And can it be soft tissue sarcoma?
Sir, maybe. Possible.
What are the complications of lipoma, Rishit? You had a confusion, just inform.
Sorry, sir?
What are the complications of lipoma?
Sir, it can, like if we were left untreated and it kept growing, it might turn into a malignancy later.
Current trend is lipoma
Never turn
into liposarcoma. Okay.
It occurs
liposarcoma is de novo.
Liposarcoma is a de novo disease. So don't tell that. So what are the other complications? Lipoma.
Retroperitoneal lipoma.
Simple thing.
Retroperitoneal lipoma and mineralization.
saponification, calcification.
Calcification.
All those things are the complications. Remember, lipo per se, current understanding is will not turn into liposarcoma. Olden days, yes, but now not. It's very poor. It's not a precursor. That is no precursor cell. So lipoma is it's a commonest tumor. Remember, it's a ubiquitous tumor. It's a short note commonly will be asked. So you should be able to write because it can occur anywhere in the body except brain, other than corpus callosum. Our brain is most our professor is which most of us don't have. So especially students don't have brain. Not that's why lipoma is not there in the brain. So my professor is to tell. So remember, that's how exactly you can remember.
Yes, sir. In Viva, we used to do that. That's the one organ that we don't use.
That's what. So lipoma is not note.
What is that?
Also in the exam. So everything about lipoma you should remember. So complications, the treatment, and different types also you have to remember. It can cause interception if it is there in the bowel. So, sir, here some Manor sir comments about the students and presentation. Lavanya, go to my PPT. Meantime,
sir, what is actually lipoma, Rishit?
Lipoma. Am I audible, sir?
Yes.
Sir,
yes.
Lipoma usually, sir, is a benign swelling which originates from the fatty mature adipocytes.
Mature adipocytes. Oma means tumor. It is called lipoma. Do you get swelling from the immature adipocytes? Immature fat cells? Do you know the name for it? It is called hibernoma. It is called the hibernoma.
When the swelling is brown swelling is hibernoma and yellow swelling is lipoma.
No, listen to me.
Sorry, sir.
It occurs in children where there is immature fat cells, which is produces thermoregulation. So you get in immature, it is called the hibernoma. In mature adipocytes, it is called the lipoma. Okay, one more complication of lipoma is saponification. Infection, saponification, calcification. That's another complication. Sir, please take over, sir. Sriram, sir.
Yes, sir. So comments about the students. Meantime, I'll just go through the exam because very common thing for surface swelling. So students, a short case, they should know the basic thing for any swelling. Next slide. So meaning, these are different meanings you have to know. Swelling denotes clear protrusion without affecting the gross nature of the part or organ, whereas a lump is defined as a lesion within the organ or causing the alteration in the gross nature, like a lump in the breast. Mass means a lesion with difficulty to define its extent, like mass abdomen we will use.
Yes.
Lump we will use. Swelling in the surface, swelling we will use. So even though it is almost same, but this terminology is very clear. So swelling is mass we won't tell. So we use these terminology in the specific locations with the reason behind it. There are the reasons why you use these different terminology in different places. It's a proper definition given in the clinical book Hamilton Bailey. Next slide. So history, just next slide. So this is the history for swelling. I'm not going to detail it. We have already discussed it. Swelling, pain, fever, secondary stages, ulceration, fungation, weather symptom, loss of function, loss of teeth. Past history, we have discussed everything in detail about that. Recurrence, there are three types of recurrence: true, perceived, persistent, and personal history. Family history is important. Tuberculosis, diabetes, family tree, they are already written. Summary of history, which already we have told. Next slide. Next. So generally, they have already discussed local. This is the local examination, inspection after consent. Already they have mentioned that. Location, we have discussed about the location. Muthukumar told in this. Ribs are important. So bony point closest to that non-mobile bone. That's important. That's what we are discussing. That skin over the swelling. That we are discussing. Color changes, mobility, pulsation. We had a discussion. Then compressibility. There one palpation. We have got a discussion where to. Also we discussed Richit. You had done a mistake in that. That's important again. So palpation, local rise of temperature, tenderness. This table shows everything, but the relevance is important. So definition of SRS or universal SRS are clearly highlighted the compressibility, pulsation, mobility of the swelling, and relation to the muscle in the deeper plane. That is also important. So inspection, palpation. This table will give a clear idea of exactly to go about while writing the slide. Next, percussion, again auscultation whenever it is relevant. Adjacent joint movement, especially in the limb, gait is important. Regional lymph node is important. Here it's above the umbilicus, axilla. Below the umbilicus, inguinal lymph node. Head and neck lymph nodes, like that. Watershed area. Relevant system examination. Spine, we have discussed in this patient, spine is important. So you have to little more you have to tell. It's a special test how to do, you should remember. Fluctuation, basic requisite, translation that already we have discussed, pulsatility, compressibility, order confusing. Only two structures commonly we come into that. Vascular diseases, vascular malformation, and lymphatic diseases. Not other, lipoma is not complicated. So definition of innovation can very clearly express what exactly it meant. Reducibility, exponential impulse, which we are now people are not mentioned in this case, it is important again on coughing. So all these special tests here look into that depending on the relevant anatomical location of the swelling as such. So you have to remember these things when you examine a swelling. Next slide. Next. So this is the same patient actually, translation, again resistance, Paget's test, fluctuation, inguinal lymph node, mobility, measurements, anatomical location, how to express. So I just put it to this one. Next slide. So again, slip sign. This is indentation, dermoid indentation. Ganglion, you can see, dermoid, you can see that. Transillumination, brilliantly translucent swelling in the neck. Is one contraction of the biceps actually, muscle becomes restricted mobility. Here again, swelling in the proximal phalanx. So we examine and you can have a conclusion what exactly it is. Next slide. So this is either you can use vernier caliper or you can use a tape for swelling or ulcer to measure actually. So spine examination, this is the adventitious bursa, this is the dermoid, cicatricial dermoid, and again it's a lipoma here. This is what Robin sir has told. Sign of indentation for the erosion, for the external angular dermoid. Here in the implantation dermoid, it's one of the dermoid where epidermis gets buried into the trauma. Again, same thing, implantation dermoid here. Again, pyogenic granuloma, or maybe skin adnexal tumor, like that it looks like. See the punctum, punctum is there in the image of it. It's very clearly seen here. Probably this is infected. Next slide. Next. So summary of the finding to analyze, correlate, and conclude. So we have to analyze, discuss that, we have correlated, we have concluded. So clinical diagnosis is important. Different causes are congenital, traumatic, inflammatory, neoplastic. All those specifications there in all books, in my book, in my clinical book, my manual also is there. Anatomical, Robbins has clearly told, anatomical, pathological. That's how we exactly look into the swelling. Yes, I mentioned during discussion, same holds good here actually. Structure of the origin, location, chin, subcutaneous, muscular bone. To all layers you have to think. Contraction of the muscle or non-mobile, fixity. Everything comes into picture while analyzing this one. Pathology again, surface, consistency, pain, tenderness, temperature, duration, all will lead to the pathological nature of the disease. So these are the different points. To guide you, give you a two parts of the diagnosis, anatomical part and pathological. All diagnosis should have anatomical part and pathological part. So these are the points clinically will you make use of to give these two parts of the diagnosis as such. Key possible differential diagnosis always, which what you have discussed, but you should be able to give reasons why it is not. So evaluation, imaging, we already discussed. FNAC, pathological is important, which you are not mentioned, but it's important. Depends on the location, you can definitely true cut, open biopsy, and systemic assessment in case if you think it's malignancy or tuberculosis, systemic diseases. And treatment, of course, wide local excision if it is malignancy or excision, Lilace if it is small, S minor or GA. If it is deep, make always things comfortable. Further therapy, if it is antibiotic, antitubercular, adjuvant therapy for malignancy. So exactly briefly, how exactly you can see the MRI here in a leg swelling. So MRI is the current standard for most of the soft tissue swelling, whether it's benign or sarcoma, or soft tissue, malignant soft tissue swellings like sarcomas. Basic investigation, which is usually accepted, but you should have a clear. If it's a simple subcutaneous swelling, we won't require to do that. Like small lipoma, sebaceous, it don't require to do that. So we should have a clinical discretion and judgment whether what the essential investigation to do or not. Next slide. Next. So you can see keloid here. You can see a large lipoma in the nape of the neck. Again, one more keloid in the ear. You can see hemangioma. This is the what is, you can see the bluish discoloration there. It is compressible, like Srinivasan told. Compressibility comes back to the original size without any external pressure or action. The word you have used very clearly, proper clinical word you have used. Slip sign is because it is encapsulated slips. Reason is also very clearly told. And neurofibroma here, this patient, one of the things that turn into neurofibrosarcoma. Only benign swelling turning into malignancy is neural tumors. Lipoma will not turn malignancy, but only neurofibroma can turn into neurofibrosarcoma or neurosheath tumors. Hard neck swelling may be malignant here with dilated veins, with a large lipoma in the nape of the neck. It's a keloid again, large here also large keloid is the keloid in the ear. Common site of keloid, it's present as a swelling. Next slide. So multiple neurofibroma all over the body. See that how it looks like. And we say swelling, maybe cold abscess, maybe swelling arising from the chondroma from the lip. After examination only we will come to know. It's again one more intramuscular lipoma in the forearm. Typically look at the encapsulated yellow fat here. This is again actually varicose carcinoma in the
Yes, sir.
In the thumb, very typical varicose carcinoma. Warty look, you can see that proliferation. Next slide. Next slide. So these are the different, just wanted to show how it looks at different conditions, so students can have idea. Look of this typical clinical look makes you have a easier diagnosis. So it's a very vast subject, but very important subject, examination swelling. So I'll request all students who are viewers to subscribe my YouTube channel. It's free. Lot of lectures are there, live sessions. I request everybody to join. We've got a great teachers like Manon sir, Srinivasan sir, Robin, and Muthukumar sir, and of course Keshav is there always. Everybody has got their own way of discussing and expressing their clinical views. So request everybody to join our regular live sessions because mainly for UGs. Just a very basic information and how to exactly go ahead with the clinical discussions. And my manual is current edition is everything is there. My clinical book also there. So I request everybody to go through that. And of course, website, please subscribe. And I thank Manon sir, my guru, Srinivasan sir. Thank you very much, Kisho, for having me always. Robin, your excellent views. Muthukumar sir always a specific subject. Of course, students have presented well, sir. Any opinion, any few words about them, sir?
Sir, the Rishit was very happy to present, I think. I was smiling and
Yes, in a cheerful mood, sir.
Very, very cheerful. But examination will be in trouble. So you have to be a little cautious about it. The other person is, I think, you dominated too much, so your partner went into depression, I think. So he's not talking that much. Okay.
Presented extremely well. So
otherwise, you answered very well. Whatever.
A few mistakes, of course, we have pointed out here mistake, not to trouble you, but this is exactly wherever mistakes will point out to correct yourself. It's basically a platform to correct yourself and understand how to examine, how to clinically have approach to a new disease, whatever this was. So reasonably, they have presented well, sir.
Yes, sir.
Good.
Yes, sir. Yes, sir.
Very nice. So thank you very much, everybody. Keshav, Muthukumar,
Thank you,
thank you, sir. Manon, sir. Robin, very nice.
Thank you,
sir. We'll have a next, maybe in 2 weeks. I will discuss with Srinivasan, sir. Their students are presenting. Next,
Yes.
I'll
Yes,
come.
sir.
Thank you, sir. Srinivasan, sir. Keshav, everybody. Thank you, all viewers.
Thank you, sir.
Please have a comment. Thank you, everybody.